Welcome to Kids Matter. I'm Dr. Elisa Minkin. As a pediatrician, mom, and grandma, I understand how challenging it can be to help our kids grow into their best selves. We are so much more powerful together. Here, I will be sharing the knowledge and wisdom of a wide range of people who understand and care deeply about children. I'm hoping for your input as well, because kids really do matter. They are our future.
Welcome back to the Kids Matter podcast. I'm really honored and really excited to be here today for the second time with Melanie Potok. Melanie is a pediatric feeding therapist, an international speaker, and a certified speech and language pathologist with over 2 decades of experience helping children and families establish healthy relationships with food. Known as Coach Mel on Instagram on My Munch Bug, she is the author of 6 books, including the award-winning Raising a Healthy, Happy Eater and Responsive Feeding. I have both of those books, and they are awesome.
Thank you.
A sought-after expert in both typical and complex feeding development, Melanie combines evidence-based strategies with real-life parenting insight. Her guidance has been featured in over 50 media outlets, including CNN and the New York Times, certified by the American Speech and Hearing Association, or ASHA, and the recipient of ASHA's 2024 State Clinical Achievement Award. Melanie has also received 8 ACE Awards for excellence in continuing education and provides training for healthcare professionals worldwide. So I'm super, super excited to be doing part 2 with you. And I think I'm going to just release them back to back for continuity. Our first talk was about normal developmental feeding tasks and the accent on feeding as a developmental task. And today we're here to talk about feeding problems, which unfortunately we're seeing pediatricians are seeing more of. And we're going to focus on something that's getting more word out, which is ARFID, Avoidant Restrictive Food Intake Disorder. But let's start just by talking about the difference between picky eating and an actual feeding disorder, including ARFID.
Fantastic. For the sake of first of all, let me stop and say thank you. It's so fun to be back here with you. I love doing this with you. I'm honored that you're having me on twice. So thank you. And it's so fascinating to me that we got to talk about starting solids and just those early signs of picky eating. And now we're starting to talk about picky eating all the way to the more extreme form, which is avoidant restrictive food intake disorder. And then where does pediatric feeding disorder fall into that? So to answer your question, I want your listeners to think of picky eating on a spectrum. So at one end of the spectrum, we have our typically developing what I call garden variety picky eating that we often see in toddlers till about age 3, maybe even 3.5. And then as we start to go up the spectrum, then at the very far end, the most extreme form of picky eating, but it's not picky eating, is called ARFID, or Avoidant Restrictive Food Intake Disorder. Somewhere in between those two ends of that spectrum is pediatric feeding disorder. And we're going to talk a little bit about the differences, but what I want everybody to hear right now, because there's a lot of confusion around this, kids can actually have both PFD and ARFID. And kids who are garden variety picky eaters can develop PFD or ARFID. And that's why it's on a spectrum.
That's a great succinct explanation, but let's go a little bit more into it because now I'm confused. What is picky feeding disorder? Pediatric feeding disorder, and how is that different from ARFID and picky eating? There's a spectrum, I got that, but
Yep.
What are they?
Great. I'm going to try to shorten this explanation for you because there's this incredible consensus paper that came out in 2024, and I'll send you the link for your show notes as well, where we really talk about the overlap between pediatric feeding disorder and ARFID. And that particular paper goes into so much detail. It is our guidepost for how we help these kids. But in short, here's the difference. ARFID is really similar to pediatric feeding disorder because they both have very similar benchmarks or hallmarks that have to do with medical complexity, psychosocial factors, fear around new food, etc. But ARFID is diagnosed typically by someone who accesses the DSM-5, which is the Diagnostic Manual for Mental Health Challenges. So that would be someone like a psychologist, probably a pediatrician as well. But most often, I'll see that diagnosis coming from a social worker or a psychologist. PFD is diagnosed by a speech language pathologist or an occupational therapist. And the difference is that now this is just my professional definition before we get into the formal definition. The way I want for other professionals and parents to think about it is with ARFID, anxiety is the biggest culprit. Do they have some overlap? Absolutely. And we're going to go into those in a second. But I want you to think about the word avoidance, avoidant restrictive food intake disorder. Anxiety feeds on avoidance. And that's what we pay the most attention to in the way that we help kids with ARFID. With kids with pediatric feeding disorder, there's an element of anxiety, but there's likely, and likely is a, put that in italics, there's likely a medical or motor or psychosocial component that's the bigger culprit than anxiety. And that's just my simplified difference based on my professional experience. Would you like me to go into more of the definition of ARFID? Would that be helpful?
So I think we'll get to ARFID later, but I really
Okay.
wanted you just to get so people understand how pediatric feeding disorders are different from ARFID. I'm going to just say it in a even more superficial way, and it's going to be limited because it's superficial. Don't get mad at me. But the way I see pediatric feeding disorders is children who may have neurological issues, children who may be developmentally delayed in oral motor skills, something like that, which is like you said, and they may be not gaining weight properly because they literally can't eat properly. And they may have anxiety, but that's not the primary thing. Whereas ARFID is more, I don't want to say a psychological disorder, but the psychological piece is more paramount. But you could have both, as you said.
You could, and you just described that beautifully, and that PFD and ARFID can look very much the same in a lot of kids, not in all cases, but in a lot of kids. But it takes a skilled pediatric feeding specialist to determine whether there's an oral motor component. It takes a skilled gastroenterologist to determine whether there's a GI component. It takes a skilled psychologist to determine how much of this is anxiety. Or if we resolve some of the GI pain, will that anxiety just naturally go away? And if it doesn't, maybe anxiety is the bigger culprit. So they're very similar. And that's why kids can often have both, because they're being diagnosed by two different professionals. But I agree with you 100%, exactly what I'm saying. The easiest way to think about it is that with ARFID, the anxiety is paramount. As a matter of fact, that is noted in the definition.
Right. I want to just, though, keep it front and center that it's not the only thing a child may have, and that you may have subtle problems that are being ignored and it's being blamed as a psychological thing. I don't think you should think either or. You always have to think what's going on with the child.
You have to think that way from the day of assessment to months after discharge, because as kids start to try new foods, definitely issues can arise. And many times when a child is being evaluated by an excellent professional like a psychologist, one thing we need to keep in mind is that they don't have the education in oral motor development, in typical feeding development, in what foods this child should be able to eat, in tethered oral tissues. I mean, the list could go on and on. Just like I don't have the education in extensive knowledge around psychotherapy, because I understand anxiety and because I understand the relationship between avoidance and anxiety, I'm a better feeding therapist, but that doesn't make me a psychotherapist.
Yes, these kids really need a comprehensive multidisciplinary approach. Good luck. I mean, that's the problem. But we'll get to that later. I want to go back to the picky eaters.
Okay.
That's more common.
Yeah.
So I really want to hear you talk about what is picky eating. Let's talk about that part of the spectrum before we even get to a PFD or an ARFID.
Yeah, let's talk about that far left of the spectrum if you want to visualize it that way. Typical picky eating, there's no standard definition for it. It's different across the literature. But in general, what we're talking about is a child who's hesitant to try new foods, but isn't so stuck on a handful of foods that they aren't willing to interact with some of these other foods, that they might occasionally try it. They might take a bite and say, no, thank you, or probably yuck, right? Because they're little kids and that's how they behave, and that's fine. When it starts to move up the spectrum is when other factors, medical, motor, sensory, psychosocial, are beginning to influence the child's ability to try new foods. And that would be true for ARFID as well.
That is a really super great, succinct explanation. I want to go back to the fact that at the mildest end of the picky spectrum, that's normal.
That's pretty normal. And there's lots of good strategies that we talked about in our previous episode. And I have in all of my books. You still want to implement the strategies because 1 out of 4 typically developing children will develop a pediatric feeding disorder. And we don't know how many kids will develop ARFID who were originally garden variety picky eaters. We don't have data on that, but we need that data.
So let's go over a few things parents could do if they have what are more mildly picky eaters.
Say that again. I missed that.
Let's go over just a few things that parents can do. I like to be proactive, right?
Yeah.
I don't want to wait till it's moving towards the right of the spectrum. What could parents do? And what would we define as normal picky eating, first of all?
We don't have a true definition of what's normal. So this is just coming from my own 25 plus years of experience. But normal is typically around 18 months of age to a little over age 3, where kids, suddenly their growth slows down. They don't have much of an appetite. The last thing they want to do is sit in a high chair because they're busy toddling about and being little kids. And so eating is not as interesting to them as it was when they were infants and they were like, give it to me, and they're tripling their birth weight, right? That's typical in that age range. And most toddlers, for example, you'll notice that as a parent, you'll notice that they eat really well one day and they barely eat for days after that. And there's so many factors that can come into play here. So what do you do about it? I want you to think variety more than volume. You're not going to get the volume in these kids anymore. They don't need the volume, frankly. Variety is how we're going to end up with an adventurous eater as they shift out of this natural stage. And so lots of little samples on the plate. I think of it like a little smorgasbord. A teaspoon of this, a teaspoon of that. And if they want more of something and it's readily available, absolutely they can have more. It's not contingent upon eating your vegetables or eat your chicken first or anything like that. This is about exploration and very, very low pressure. And I say that because we often say no pressure, but the truth is just when we're playing in food, when we're being silly with food, when we're putting food on fun chopsticks and toothpicks and all of that fun stuff, it's still an indication to give it a try. So that would be the tiniest bit of pressure. And I'm okay with those little nudges. So that is sort of your typical picky eating. If you notice that your child is having big emotional outbursts consistently, you're really stressed about meal times, that they have trouble chewing or they cough a lot when they swallow. We could list probably 50 more things. Always talk to your pediatrician about getting a referral for a pediatric feeding evaluation. And although it isn't always possible to get that through early intervention, we talked about that in our last episode, there are ways to get some support, and your pediatrician is going to help guide you. And even if it's something as simple as just grabbing one of my books, but I really, really love those kids to have an evaluation in person, because sometimes it's a really simple change that we make, and it takes a professional to see that with some experienced eyes.
Right. And sometimes they can get an evaluation but not qualified, but the therapist who evaluates give those tips.
Right. Yeah. We sure do.
You know,
try to send parents home with as much as we can.
Yes. And I want to add, though, we said this in the other one, but I'm going to say it again. If your pediatrician says the child is gaining and growing fine, it's not a worry. That's not necessarily true.
That's not necessarily true. Well-meaning advice but, and, trying to comfort that parent. But the truth is, I have plenty of kids on my caseload who are only eating 3 foods and are a little bit overweight. It doesn't mean they're getting a good balanced nutrition, but it also doesn't mean that they're a part of family meal times, because food isn't that interesting when you only eat 3 foods. It's just a
Right.
job.
Right. And it's also the the normal weight gain and growth is kind of masking that there's actually a disorder.
Exactly.
And talk about masking, I have a big issue with Pediasure, because a lot of times the child may not be gaining, and then they'll be told, well, to have Pediasure, either the parent will choose it or the physician or a clinician or whatever. And that also will mask a feeding disorder.
Well, and that's one of the criteria for the diagnosis of ARFID is dependent on a nutritional supplement.
Right. Which is not to say that there's no role in the supplements. We're not saying that.
Not to say that at all, but when you're dependent upon it, some kids very grateful that we have those supplements, but we don't want to create a dependency when there doesn't need to be one.
Right. And if there is a feeding disorder, pediatric feeding disorder, or ARFID, it has to be addressed. It can't just be give them Pediasure. That's how they'll gain their weight.
100%.
Okay. I would like to move on to ARFID. I'm ready.
You're ready.
What is it and how is it different from all the other things?
All righty. What I want your listeners to understand, and this is in brief because the definition is quite long, I'm just going to give you some little tidbits to help you understand the differences. Again, remember, there was a pivotal 2024 consensus paper that was brought to us through the wonderful feedingmatters.org, and it helps us clarify the overlap between PFD and ARFID. So let's jump into ARFID. They're both very similar, but ARFID is an eating disorder, yet, and I really want everybody to hear this, it's a feeding or eating disturbance. So it's under the umbrella of eating disorders, but it's classified as a feeding or eating disturbance, very similar then to PFD. And it's a persistent failure to meet those nutritional or energy needs, as we were just talking about, either because the kiddo has significant weight loss or failure to gain, and or significant nutritional deficiency, and or dependence on supplements or even a tube feeding, as we just talked about. And the fourth one would be marked psychosocial impairment. If we have time, I'd love to talk more about that one, but let's keep going in terms of the definition. The other thing you want to consider with ARFID is that the behavior is not due to a lack of food or to a culturally sanctioned practice like fasting once a week for religious purposes. It's not anorexia. It's not bulimia. There's no disturbance in terms of how you view your body shape, your weight, etc. It also can have underlying conditions, as we discussed about earlier, but those other medical or mental conditions are not the biggest culprit. The severity of the eating disturbance itself exceeds those that are routinely seen in kids who have that same medical or mental condition. Let me give you just 2 random, right off my caseload examples. If I have a kid with a cleft palate, he goes through years of surgery, he gets all the repairs. If he still has a lot of trouble eating, and now it's based on fear, then that likely is going to morph into a diagnosis of ARFID, where prior to that, it would have been pediatric feeding disorder because the cleft palate was the biggest culprit.
Oh, I see.
And
that would be for tube feeding as well. Children, I'm sorry, I mean, but children who've been tube fed very commonly develop what we call a feeding aversion. Would we now call that ARFID?
No, a feeding aversion, that's a great question. A feeding aversion is a general term that where ARFID is right out of a diagnostic manual. So all of these kids have a feeding aversion, whether it's PFD or ARFID. In the same way, I think about it in the same way as just calling someone a anxious eater.
But a child with a feeding aversion has anxiety as the reason they're not eating, and that's what ARFID is. So would feeding aversion be a subset of ARFID?
No, it's a great question, but it's more that feeding aversion is a general term in the same way that I'm a really tall girl. I'm 6'1".
Oh,
So
wow.
tall girl is a general term, if that makes sense. All of it is true, but it wouldn't be a formal diagnosis. It's
I
more
see.
of an observation.
I
So
see.
I really like the way that you brought that up, because I think that can be confusing for parents. Um, when we talk about ARFID, it presents three different ways. I think of these as subtypes or maybe even hallmarks, and it can present either as sensory avoidance. And I'm not just talking about sensory avoidance in terms of like hyper or hyposensitivity in the oral cavity, like, oh, that's a lot for me, right? But think of eating a raw oyster. There's some sensory avoidance for a lot of people, right?
Mm.
It can also be hypersensitivity to the emotional characteristics of food. Those are my kids on my caseload with ARFID, who inspect every single French fry because it's got to be just right. That Christmas, like it's got to be just right crispy, or they just reject that French fry. So there's an emotional sensory component there as well. The second presentation or subtype would be this lack of interest. And that's where they don't really have a great hedonic appetite, a great homeostatic appetite. And what that means is they don't find a lot of pleasure in food, and they don't really feel that hungry until they're really hangry. And then the third one is typically based on a fearful episode around food. Cyclic vomiting syndrome would cause this. A choking episode can create a situation where a child now has ARFID. But I do want to tell you something interesting that I've never shared with you before. During the pandemic, I had 3 kids come on my caseload who all had that third subtype, the fear-based avoidance of food, but it was not due to a food trauma. It wasn't due to vomiting or choking. One got a jelly bean stuck on their tooth. So I guess that's food, but they couldn't get it off. The other one, this is so sad, but her parents were getting a divorce, as many parents did during the pandemic. And that just tipped her anxiety bucket. So she started to assign all of those anxious feelings to food, because
Wow.
you can control food. Now, she had a history of pediatric feeding disorder. She actually saw me as a young child. And then 4 years later, it's been eaten great. This tipped her anxiety bucket. And so she tried to control food again to reduce her own anxiety. So I'm sharing just a couple examples because although it's not described that way in the literature, in my experience, I've seen a handful of kids that there wasn't an issue that was immediately about food, like a choking incident, like trauma, a traumatic incident like that. It was something else that filled their anxiety bucket, and they decided to control the food to help themselves feel better.
Wow. First, I just want to go back again. I don't want to keep reading, but that feeding aversion looks like it falls under that category. So I'm not so sure that those children who were tube fed, who have a learned aversion or a feeding aversion, might not be in that same category. As a trigger of this maybe later?
Absolutely.
Okay.
No, I think you bring up an excellent point.
Okay.
It's
And the other thing,
complicated, isn't it?
yes, it really is. But I love that we now understand it not as just some kind of vague anxiety, but there's specific pathways into this so we can understand how to help them. We're going to get to that. I just want to say one more thing. When you talked about COVID, the pandemic, we as pediatricians, we're seeing more and more of this, like out of the blue. It used to be so rare. And I'm wondering whether it is that anxiety control dynamic, because
I truly believe that's the case. I really hope we'll get some good data through those years. I want all of your listeners to think about anxiety. You know, we all carry a bucket of anxiety with us. It's there to keep us safe. It's so that we don't walk out in front of a truck when we cross the street. That's good anxiety to have. It's called adaptive anxiety. But some kids have a bucket that's more full than the neighbor. Some kids are just more anxious than other people, and that's okay. But when you throw something like a pandemic at them, you can only imagine what their nervous system was going through. they're carrying a very heavy bucket of anxiety water, and that's a burden to carry. So they look for ways to find relief. And typically human beings find relief from the feeling of anxiety by avoiding what they think makes them feel anxious. And food shows up 3 times a day plus snacks. So it's easy for kids to assume that it's the food that's making them feel this way.
That is really, really helpful to understand. And I'm thinking back because my own daughter, had a feeding disorder, and she would have qualified for ARFID because she was dependent on, for a very, very long time, for 4 years, on, a Pediasure type thing. So I see all the different pieces there. And what I'm thinking now is that at the time, anyway, the methodology was behavioral and not addressing anxiety, desire for control, or any of these things. It was assumed to be a behavioral problem, and the approach was like ABA based. I think it still is in some feeding centers.
I mean, that's a whole nother episode for sure.
Yeah. Sorry.
And as someone who has a strong background in behavioral psychology, I have to say that one of the things I teach in all my courses is behavior can be a great thing. We're all doing a behavior right now, every single second. As long as you're alive, you're doing a behavior. But we tend to think of the word behavior in a negative way. We need to think of behavior in across the spectrum of desired and not so desired. And that's just called parenting, right? Pay attention to the behaviors you want to see and don't give the other ones much attention. And you'll usually end up with some pretty great kids as they grow up.
Right. But the reason that I'm bringing this up, and this is a little bit of a segue into something else in my notes, which is to talk about skill deficits, right?
Sure.
So if you're treating it as a pure anxiety or a pure behavioral choice when the child really has skill deficits that you're not addressing, I don't see how you can help.
That's a great point. So the best way I can explain it to your listeners is that you want to consider the whole child. Behavior is the hat they wear. And if you only focus on the hat and you don't focus on what's underneath that hat, then you really can't change behavior because behavior is a form of communication. So if that child is turning away from the food because they actually have eosinophilic esophagitis and they desperately need to see a gastroenterologist and a specialist, then that's because they're turning away because they're in pain, right? So we always want to look at the whole child. We try to manage the GI piece, the sensory piece, the motor piece of the child's having difficulty chewing or the mechanics of swallowing, et cetera. We don't always fix them. Some things you manage well, but we manage them to a point where the child now has the skill and ability to change their behavior.
I love that. And you're talking about eosinophilic esophagitis, which is often missed, by the way.
Yes.
So I want to talk a little bit about medical rule outs. I mean, maybe it needs to be on my part because I'm the pediatrician.
Yeah.
I mean, I've definitely seen kids and we're going to talk later about kids on the spectrum and how more common the feeding disorders are there and that they may not be able to articulate it and just show behaviors as indication. What do you think? I had read somewhere that ARFID is a diagnosis of exclusion and all medical rule outs have to happen first before you can say it's ARFID. Do you agree with that?
It depends. I know.
Thank you. No, I don't.
And I say that because every kid's different. But in general, as you mentioned earlier, these kids need a team that they can count on. That's not always possible to form a whole team right away. But I'll tell you, every kid who comes to me first, and if I'm the first point of contact, even if they're not complaining of stomach issues or constipation or difficulty swallowing, I get them on a pediatric gastroenterologist wait list. It's going to take, 4 or 5 months to get in to see them anyway, especially if there isn't any urgency. That way, I can begin to gather information and start to work with this child. By the time we get to the GI appointment, I have so much information to give that GI doc. And even if the GI doc just puts those very experienced hands on that kid's belly and is just doing sort of a screening process and says, keep in touch with me, I now have them on the team. So I'm a big fan of it's up to the parent, but every child that comes my way goes to see a GI doc if I can encourage that. And sometimes it might be an allergist, a specialist in EOE, because not every GI doc specializes in eosinophilic disorders, So yeah, it really varies which professionals will be on that team. To answer your question, because I could talk about this all day. To answer your question, it is very common in my experience, for kids who come to me with a referral from a psychologist, that psychologist is diagnosed ARFID, but they may not have the knowledge that child may need to see other experts in the field, but they're often relying on me because I do have that knowledge to manage that part of the team. So it's a process to get all these people on the team. So yes, you're going to get kids who have the diagnosis of ARFID without all that precursory evaluation. But in my experience, I'd love for them to pursue it because this takes a lot of detective work.
I love that so much. And I love how you phrased it, that it's a process and you're building a team. And the reason that I want to underscore this is because you don't want the child to be waiting to first see a gastro to clear him, because this is a mentality that some of us have, that we have to first do medical clearance. It can be done at the same time and even see the feeding therapist first, because you're trying to help the child. It's not a matter of does the label fit. It's a matter of helping the child. And if you see the child first, you're going to pick up things that you can help direct the team.
Hallelujah.
I knew you would love that.
Sing it louder.
But it can be a hard concept because parents will often think, I don't want a psychological diagnosis. Let's make sure we've ruled out everything medical. And I think it's wrong to think of it as a psychological diagnosis anyway. I think it's wrong to think of it as an end stage rule out anyway. But you're also underscoring the importance of the medical piece, not to ignore it. So important. Exactly. It's that whole mind-body dichotomy that's a false dichotomy.
So many people are really crucial to helping these kids. And whoever that first point of contact is, they're going to help to form the team from there. So I am never going to criticize a mental health professional who doesn't send them to the GI doc first. I love that they send them to me first, right? Because I have those connections. I know who to send them to here in Colorado. I know how to create that team. Give them to me.
Right, from the pediatrician.
I'll work in a transdisciplinary way with the mental health professional.
Right, and from the pediatrician medical, standpoint, I'm seeing don't wait too long to refer to the feeding therapist, because you can do the medical stuff while you refer and let the whole team sort of build. And as a parent, I always say you've got to build your team. It'd be wonderful. You always had these interdisciplinary centers, but that's not a reality for most of us. I just want to quickly mention a few rules just so they're out there. I have on my list reflux, right? Gastro reflux. I have eosinophilic esophagitis, which is not something you can see. You have to test for it on biopsy. Irritable bowel syndrome, inflammatory bowel disease, celiac, very often missed, neurologic abnormalities involving tone and development, food allergies and intolerances. Most of these are gastro, some is allergy, some is neurology. So really ask your pediatrician and be your child's squeaky wheel.
Love that.
So I want to move on more about ARFID. We talked about pretty much the things I wanted to get to so far, which is great. But I want to get to, how does ARFID develop? It doesn't come out of thin air, right?
Well, that's something we're still learning about. But here's what I know for sure. Dr. Nancy Zucker from the Duke University Center for Eating Disorders, she's founded that program. She did some incredible research that's in the journal Pediatrics, where she showed us that kids who are in the preschool years, in that garden variety picky eating stage that we talked about earlier, that when they demonstrate moderate to highly selective eating behaviors, they are at a significantly higher risk for 3 mental health disorders: anxiety, depression, and attention challenges, ADHD. So if we have kids who are moderate to highly selective eaters in the preschool years, we don't have the data yet, but if they're already at risk for anxiety, depression, ADHD, In my mind, they're at risk for ARFID because we know those come into play as well for kids who have ARFID. I think we need to start connecting those dots.
Also, autism.
Oh my goodness. Do you want to talk about autism? Because I can talk about it.
Go for it. To me, that's just the pinnacle of what leads to eating disorder, like the most highest comorbidity of all of those.
Boy, that is the case. And I have such a special place in my heart for my autistic friends. Having been on the team to help with the evaluation and the treatment at the local hospital, and they are my heart and soul. So I love talking about them. Our autistic children are up to 5 times more likely to experience extreme picky eating than those children who are not autistic. Various studies report ARFID prevalence to be between 8% all the way up to almost 55% with our friends with autism. So we still need to get more distinct data. About 40% of autistic children also have an anxiety disorder. See the connection here?
Yeah.
Up to 55% of kids with ARFID also have an anxiety disorder. I teach a on-demand course all about this, all about autism, ARFID, and anxiety and the relationship. I call it's the triad that's not just picky eating. And I'm just so glad you brought it up because these are the kids who really can get so much better if we address this early, and they're more likely to have challenges around food.
And this is true, by the way, for eating disorders in general. We mentioned ARFID being potentially under the umbrella of eating disorders.
Yes.
There's also a very high rate in the eating disorder population of being on the spectrum.
Is
and
that
that's
right?
absolutely, and that's going to be a separate episode in the future. I have someone to interview who's an expert on that, a psychologist.
Oh, I'm so
From
fascinated
Equip,
about that.
from Equip, the online eating disorder program
Yes,
has an Equip
yes.
Academy, and I heard her speak. Carly Knaup, Knaup, I think. Anyway, yes, I'm planning on interviewing her, and I guess that'll be the 4th of the series if you think about it that way.
That's right. I'll definitely
it's-
tune in.
It's really, really important because I'm trying to think about it in a proactive, preventative way, which is let's understand the comorbidity of eating disorders and ARFID and selective and picky eating with neurodivergence, right? Because it's also common with kids with ADHD. And let's, first of all, when we see the eating disorders, think about the neurodivergence. And when we see the neurodivergence, think about preventing the feeding issues by picking them up early. That's what I think.
Absolutely.
So I think that's something that we can do. What happens if you don't treat it early? What is the outcome of untreated ARFID?
It's interesting that you asked me that question. You had told me that you wanted to chat about that. And I really stopped to think about it. And I started doing a little bit of research. I just got back from teaching the pediatric team at the Cleveland Clinic. And I was really honored to be asked to come in and teach. And I presented my ARFID masterclass there. So before I went, I really took a deep dive onto the Cleveland Clinic website. And that's where a lot of this information that I'm going to share with you comes from. So the outcome of untreated ARFID, because remember, adults can get diagnosed with ARFID too. We're talking about kids in this episode. But first of all, severe physical health complications. And that's where we were talking about before malnutrition and nutrient deficiencies, that chronic lack of calories and very specific vitamins, et cetera, can weaken their immune system. It can change their electrolyte balance. We can go on and on. Growth and development, of course, which we've touched on. Not just faltering weight, but also stunted stature and delayed puberty as well. And then cardiovascular and bone issues, low blood pressure, irregular heart rates is something I often see. And it's noted on the Cleveland Clinic website that osteoporosis is also something we could be concerned about. And that makes sense because we build our bones from childhood.
Right.
GI distress, we've already talked about. But then there's the psychological and emotional impact. This is the part that I get the most phone calls about, honestly, where the kids don't want to go to the neighbor's slumber party because, yeah, they really want to go, but they don't serve pizza with no sauce and the crust cut off, which is just the bread. That what the kids will say to me, well, that would look weird, so I'm not going to go. That breaks my heart, but they want to go. So These kids often have intense anxiety. We talked about the fear of choking, vomiting, etc. The social isolation that we just talked about. They would love to be a part of things, but they are too worried about how their eating might be perceived. And also, we've already talked about depression and, of course, anxiety overall. So when we think about the overall impact, you can't just focus on the physical aspect. You have to remember there's a psychological aspect here too. And the last point that I want to talk about on that is that then bleeds into their school, their summer camps, their family life. And after a while, in my experience, those kids, they don't know how to see themselves any differently. They have no hope that they can, quote, get better. So they just accept that this is who they are. But they desperately want to be a part of all those other social experiences that we want our kids to be a part of. But most social experiences involve food.
That is so true. So let's talk about the anxiety accommodation problem, because you've really been emphasizing the anxiety piece and how it can limit the children, which is true for anxiety in general, right? If it's been accommodated.
Yes, yes. And that's one of the things that I work with the parents the most. These are wonderful parents, wonderful parents. But if you go into your local bookstore and you are looking for a book on how to parent your 6-year-old, you're going to find 20 different books. And there's even very specific books on how to parent the anxious child. And that's so important for parents to understand. There are a lot of different parenting styles. And when you have been gifted with an anxious child, because there's a lot of great aspects of that, then you need to know how to parent that child a little bit differently, especially if they're anxious about food, especially if they're anxious about food. So it's just like that, my friend, Dr. Jonathan Dalton, who is an amazing psychologist, always uses this example. When you have extreme levels of anxiety, you're a Ferrari and you have to learn how to drive it. You have to learn how to take care of it. You have to learn how to put the right kind of fuel in it, the right kind of additives, and take care of the tires in a certain way. But man, are you flashy and people love you. You're not a Toyota Corolla.
You make me
No
want to be more
offense to
anxious.
anyone who drives a Toyota. But I love that example. Being a highly anxious kid can really be a superpower, but you do need to know how to parent those kids.
I love that so much. That is so, so awesome. So let's just talk for a few minutes about how to treat ARFID.
Yeah, it takes a team. Fully recognizing that the therapists that I teach across the country and in other countries as well, a lot of them are in rural communities and there isn't a GI doc within 2 hours. So ideally, we want to create a transdisciplinary team. And here's how everyone will approach their role on the team. Maybe I can't say everyone because we could have 20 people on that team, but let's say the GI doc, their primary role is GI health. The RDN, the registered dietitian nutritionist, their primary role is nutrition. Do they overlap with the GI doc? Absolutely. Does that mean they're stepping out of their scope of practice? No. That just means they're educated. For an OT or an SLP, our primary role on the team is to build skill and ability so that child can develop their primary role, which is internal motivation to change. The parent's role on that team is to support the child and to follow through as best they can with our strategies that we provide. The psychologist or mental health worker's role on the team is primarily to provide strategies to help the child not reduce, but manage their anxiety and stop avoiding as a way to reduce that anxious feeling. Do I also need to have knowledge around that because I'm in a feeding therapy session? Absolutely, because I'm going to see the worst kind of anxiety because it's around I got the food, right? So for me not to be educated on that is, I think, irresponsible. But that doesn't make me a psychologist.
Right.
So think of our roles as overlapping just a bit. Everybody stays in their lane, but a little bit of crossover as you're driving your car is still safe. It's knowledgeable. You know to get back in your lane. You know to consult with the other people driving the caseload, right? Think of it however you want. But I guess what I'm really trying to express here is that we are actually going to do more harm by being obsessed with our scope of practice. I would rather see us being obsessed with our role and how it overlaps with other professionals so that we can give this child the team they deserve.
And again, if you don't have access to this multidisciplinary team that just coalesces effortlessly in front of you, as the parent need to be the team leader and build it.
Absolutely. Absolutely. And if you're an SLP or an OT, you need to have the education that we don't get in graduate school around anxiety so that you don't do any harm. It's really tempting when you see a child who's very anxious to back off quite a bit. You just let them avoid even more. The skill, the art to this is knowing how much to gently nudge. We don't want to shove, but how much to gently nudge to help that child become unstuck. Because kids with ARFID are stuck.
You know, that's really an important point, and I want to bring up the role of the family and the parents, because one issue that I have is you send the kid to therapy 1 hour a week, half hour a week, whatever it is, and then they're home the rest of the time. And I think we neglect to support families, parents with this. And you alluded to it with the anxiety piece. And I'm just going to mention that I did interview someone on SPACE, which is space therapy, which is supporting parenting of anxious childhood emotions. I think I got that right.
Right.
It's hard to find people trained in that. They're there. But even if you don't find that, the idea of supporting the parents to manage their children's anxiety and their own anxiety around their child's anxiety, right?
Yeah. Children's Hospital of Philadelphia did an excellent study on that, where they had a large sample of kids who were, quote, extreme picky eaters. They did evaluations on all of them, and they narrowed it down to, please don't quote me on this number, I think it was 23 kids, it was right around there, and who had the diagnosis of ARFID and no other developmental delays, just for the sake of this research. And then they didn't treat the kids. They taught the parents how to parent differently. I'm not saying the kids didn't end up in feeding therapy 6 months later, but they took 2 months where they just provided parents with strategies on how to parent an anxious eater. And it worked. And that's why I really want to stress, as we finish up here, that the change in the child sometimes begins with the change in the parent. As wonderful as they are, they're amazing. They may have to learn to parent a little differently because no two kids are wired the same. We can't expect to parent every single one of them exactly the same. So knowledge here is really power, especially when it comes to an anxious eater.
That's really true. And again, we're not blaming parents. We're not saying it's your fault. We're not saying you're making your kid anxious. And as a
Not at
parent
all.
of a child with a feeding issue, it is so hard. It is so primal. You just want your child to eat and gain
I
and
get
grow.
it. Absolutely.
So hard. And so I'm going to beg parents listening who don't get this naturally as part of their team, find someone to help you.
Yeah.
Might not be a space therapist, right? Find someone. It could be your own therapist.
Well,
Somebody.
I teach an ARFID masterclass that's super popular. I limit it to only 22 therapists. Parents can attend too. And that's exactly what we talk about. And it is all about our response to the child's anxious behaviors and how we can help that child learn to sit in uncomfortable and realize they're okay. That's a life skill right there.
It's also so helpful to the child to grow as opposed to stay stuck, right?
Isn't that the truth?
So this is a great place to end because we could talk about this all day.
All day.
I just want to say one more thing before I forget, and that is to parents, people listening, you deserve progress with your child. It might be slow, but one sign that you're not getting the help you need for your child is not seeing enough progress.
That's right. And have that conversation with your therapist. We want that feedback so that we can all make sure that we're providing the best support we can, not just for the child, but the entire family.
Right. And we can't say how fast that progress should be, but use your intuition. If you keep getting told, oh, it's just very slow, that's just normal, and your gut is telling you, no, you can ask for a different therapist. You can switch.
And our feelings will not be hurt.
The important thing is
absolutely okay. But most of the time, it's just honest communication. I think parents are afraid naturally to bring it up because they don't want to hurt anybody's feelings, but we actually really appreciate it. We want that open dialogue. That's how we help these kids get better.
Right. And you might say, go back to your pediatrician and find out that you missed something in the gastro field, for example. I'm just throwing it out there. So you need to be the squeaky wheel. You are your child's best advocate. I want to thank you so much for doing this with me.
Thank you for having me. One of the best things is not only been just being able to talk about what I love, which is food and family and kids, but also getting to know you. I appreciate everything that you do. So thank you.
We make a great team.
We make a good team.
Thanks again.
Thank you for listening to Kids Matter. Raising healthy, happy children takes a village, and I'm grateful you're part of ours. If today's conversation resonated with you, please share this episode with another parent, grandparent, teacher, or anyone who cares about kids. Together, we can build the supportive community our children deserve. I'd love to hear from you. Share your thoughts, questions, or suggestions for future topics at kidsmatterpodcast@gmail.com with no exclamation point. Your voice truly matters. Until next time, keep advocating for the children in your life because kids really do matter. They are our future. I'm Dr. Elisa Minkin, and this has been Kids Matter. Please note that while I am a pediatrician, I am not your child's pediatrician. This podcast is for informational purposes only and does not constitute medical advice. For any medical concerns or decisions, please reach out to your child's healthcare professional.